Okay, I think we're good to start. You're very welcome to our 5th lecture in our Pediatric Aerodigestive lecture series. This week, we're having anesthesia, and I'm privileged to give to us the first introduction to Mary T. Nabukenya. Dr. Mary T. Nabukenya is a lecturer in the Department of Anesthesia and Emergency Medicine at Makerere University, Kampala, Uganda. She is a pediatric anesthesiologist at Mulago National Referral Hospital in Kampala and is an affiliate instructor for the Department of Anesthesiology, Pharmacology and Therapeutics, Faculty of Medicine, University of British Columbia, Vancouver, Canada. She has a keen interest in capacity building and advancement of pediatric anesthesia and critical care in Uganda and the African region, as well as safe and quality anesthesia practice for all. She is also the president of the Anesthesia Society of Uganda. So without further ado, I will welcome Mary. Thank you for being on this call today. And sorry that you're in theater. I hope no one will come rushing for you while you're giving this talk.
Thank you very much, Fiona, for that kind introduction. Good evening, good morning, good afternoon, everyone. It's a privilege for me to be sharing with you this evening. Let's see if this will work out. So Fiona asked me to say something on anesthetic considerations for patients that are going to have aerodigestive procedures. It will not be very much about the anesthesia itself. It will be a little more about maybe some tips that you can use, because you can read about a lot of the anesthetic considerations. I'm by no means a world-renowned expert on the topic, but I'm a lifelong learner, and I have learned and picked up a few things along the way. And I'd like to acknowledge my colleagues that have made a contribution to my talk. So the topic of, I'm going to switch off my video because it tends to interrupt the wavelength, it disturbs the wavelength. So I find that with these aerodigestive procedures, the anesthetist and the surgeon must be very close friends. They must have a close relationship. Otherwise, the patient suffers. So what kind of patient are we talking about? It's a wide range of procedures that might fall within this topic. So it's your 10-year-old boy with tracheal polyps or papillomas. It's your 7-month-old baby who was born with a congenital heart disease and has a possibly tracheoesophageal fistula, the H type, and has been having recurrent upper respiratory tract infections, and the surgeons want the ENT surgeon to do a laryngotracheal bronchoscopy to help them figure out if there is a fistula or not. It's your 2-year-old baby girl with a foreign body in the airway. It's all those suspension laryngoscopy procedures. It's your adenotonsillectomies. It's a whole lot of cases. And the thing about these cases is that they can be quite stressful for the anesthesia provider, because sometimes you feel the surgeon is being a bit demanding in not wanting you to put in an endotracheal tube. We want a secure airway, but the surgeon wants to work without anything in the airway, in their space. And then, you're looking at the video and suddenly the screen is full of blood. The masses are huge. It can be quite hair-raising. These are children whose histories are such that they tend to have pre-existing respiratory risk factors. which increases their chances of getting critical respiratory events. So in cases like this, even when you don't have an obvious anatomic derangement, it's important to anticipate a physiologically difficult airway, because it's going to increase your risk of respiratory events. It tends to decrease your first pass success rate if you intend to intubate the patient, and then there's an additive risk effect. And so it's very important that you approach these patients with caution. It makes for, these cases make for great examples of how to teach how human factors can influence patient outcomes. And what might be an easy surgery may not necessarily be an easy anesthetic. There's a host of complications that commonly happen in these cases. So you have desaturation. Sometimes it's so scary, they can go as very quickly down to scary numbers. I'm sure a lot of us have seen, sats of 60s, and then it keeps going down, despite the fact that you've put back your mask and you're trying to get the saturations back up. They can get laryngospasms or bronchospasms, and if these are not broken fast enough, you may end up with negative pressure pulmonary edema. They tend to get airway obstruction. If you think about your patient that has obstructive sleep apnea, they're very sensitive to sedatives, opioids, the surgeries that are happening in the airway. Blood can get into your endotracheal tube and block it. The surgeon puts in a gag during an adenotonsillectomy and obstructs the tube. They've been scraping away in the airway. The patient wakes up with an edematous airway. We put in a pack and forget to take out that throat pack. And then, of course, there's always the risk of displacement of the tube, and the patient may take long to wake up, and a lot of other complications. And so it's important to think about, how you want to go about the case. And these are things that maybe you want to think about for every one of those cases. Think about the team. Is it enough for the patient that it's just you and the surgeon, or must you involve other members such that you have a multidisciplinary team discussion before you even plan and schedule the surgery? Communication is paramount. I feel that if you cannot talk to the surgeon, if the surgeon can't hear what you're saying, and if you can't hear what the surgeon is saying, if it's not an emergency, you should probably step out and let someone else that can, can make for better communication come in, because it's very important for the communication between the surgical team and the anesthesia team to be good. And then just a bit more about the communication, even within each group. But I'll speak specifically for anesthesia. If you're the team lead, your team needs to know what's going on. You need to share your mental model so that everyone on the team knows what the plan is. Everyone knows what plan A is. If plan A fails, everyone knows what plan B is. Everyone knows what plan C is. And then it's important for us to understand the surgery and what's going to happen and what steps are going to be taken, because it helps you to plan the anesthetic, and it helps the surgery to be smooth and end, possibly in a shorter time than if you're not prepared. And then it helps to be adaptable to the situation. You may plan one thing, and then it ends up, you may end up in another way. The important thing is, if you have prepared and anticipated all possible scenarios, even when you have to change in the middle of the case, you're not, the changes are not shocking to you, and you sort of had everything ready just in case. It's important to have your useful tools, and we will talk a bit more about that. And then if you can come up with some protocols for some of these cases, that can be very helpful. I can't emphasize this enough. You need to prepare, you can't prepare well enough. You have to think about everything that you might possibly need. You need to make a plan, you need to collect your tools and equipment. If you consider your setting, sometimes the equipment may not even be in your hospital. And part of your planning might mean calling a certain person who might be out of town, and then you have to figure out when are they going to be in town. Or there's the one ENT surgeon that has the pediatric flexible fiber optic scope, and she's only available on the Friday afternoon. And so, those are all the things that you have to put into consideration. And so when you're preparing and making your plan, you have to think about the things that you need, the people that you need, and what you need to make your plan happen. So let's talk a little bit about tools. So part of your tools is your crisis resource management skills, because they come in handy when we have a crisis. So it's knowing when to call for help. It is anticipating all possible scenarios and making a plan for them. It is being able to mobilize resources, use your cognitive aids, and communicate effectively, and exercise good leadership. Another tool to think about is your guidelines. It's important to know them, but you don't have to recall them from your head. So if you can pull up the guideline that you need on your phone, which is why it's important to have an assistant, because your hands are going to be occupied. So pull up your phone or ask your assistant to pull up their phone, open that algorithm, and we just go through it. I put this QR code. It's for this BJA journal article. They recently published some guidelines on the airway management in neonates and infants by the Europeans. And there are some things that I did not, they didn't settle very well with me, but I think it's a really good paper. And even if it's called airway management in neonates and infants, I think there's a lot that we can pick from it. And some of them are things that we may already be doing, but I'd recommend all of us to just go and take a look at this paper. So your tools include your kit, socio kit. I don't know how many of us work in settings where you have a difficult airway cut that looks as nice as the picture on the left. But for most of us, you really have to go looking around for what you need. And it's important to have it near you so that when the crisis happens, it's not, the one new resident in the OR who is the free hands going around to look for something that they're not sure of and they have no clue where to find. So it's important to source your kit early and have it close by. It's important to have those conversations, and the first one will be going to do your preoperative assessment. The article that I have talked about, that talks about airway management guidelines in neonates and infants, one of the things they recommend is using your preoperative, your history and physical exam to diagnose a difficult airway, to make a diagnosis. And I think it's important for us, right from the outset, when you're having a conversation with the patient and meeting their family, to get a sense of what complications or what difficulties the patient poses to you as the anesthesia provider. And I said plus or minus talk to the surgeon, because this might be the time you start to think, okay, this child is going to be very complicated. I need my colleague who has skills in using flexible fiber optic, because there's no one in my hospital right now that can do that I can trust in this situation. And we will need to plan that. So the surgeon can, maybe reschedule the patient to accommodate the needs that you may have. And then on the day of surgery, it's important to have a team brief. And what that is, you have everyone on the team, the surgical team, the anesthesia team, the nursing team, and anyone else that's going to be in the operating room. Everyone introduces themselves. You talk about the cases for that day. Everyone talks about their concerns. It's important during these meetings to ask if there are going to be any special steps. Does the surgeon need anything in particular? And then anesthesia, you make sure that you have what's needed. Just helps you to prepare and everyone to be on the same page. And if there's anything else that's been forgotten, that would be a good time to talk about it. So let's talk about the anesthetic. Again, the patients that have this kind of surgeries are going to be a broad range of patients, but there are some for whom you want to think before you give premedicants. So again, your child with obstructive sleep apnea, should we give them premedication? Your child with the big airway tumor that's displacing their trachea or extending into the chest cavity, should we give that baby premedication? So it's those things that you have to think about. You may have to refrain from using sedative premedicants in some of the patients. And then, do you want to instrument the airway? And if you do you want to do it awake or asleep? Awake intubations can be done in children. It's not very common because obviously we may not get good cooperation from them. So we tend to put most of our patients to sleep. And then, the question again is, if we're going to put them to sleep, do we want to paralyze or are we going to maintain spontaneous ventilation? It will depend on the surgery that's going to happen and the discussion that you had with the surgeon, what they want for the procedure. And so you work accordingly. Sometimes, so if you go ahead and paralyze the patient, because we're dealing with children, we've talked about the category of children that we have. Chances are high that they're going to have hyperreactive airways. Even without a hyperreactive airways, children have a high metabolic rate and high oxygen consumption, so they desaturate really fast. It helps to use your apneic oxygenation. Some anesthetic workstations now come with high flow nasal cannula, oxygen attached. And in some settings, you might have a separate machine for that. And this can give your patient up to 60 liters per minute of warm humidified oxygen. But not to worry, for us in the low and middle income countries, you can still use your simple nasal cannula and just crank the flows up. You can't give much more than 8 to 10 liters, unfortunately, but it does buy you some time. Sometimes you may elect to intubate the patient, but maintaining spontaneous ventilation. If you're going to do that, you want to avoid all the potential complications that can happen if your patient is not deep enough, right? You don't want to get laryngospasms, you don't want to get bronchospasms. So in order to optimize that, you have to make sure if you induce the patient with gas, you want to make sure it's a deep inhalation anesthetic, or you might want to give some propofol boluses. I would restrict that to maybe 1 to 2 milligrams per kilo, just so you don't make your patient apneic. And if they go apneic, it's not for too long, just to allow you to intubate your patient without incident. If, on the other hand, the procedure requires a natural airway, you have to figure out a way to maintain oxygenation. So in this procedure, the surgeon has a rigid telescope, and it has no provision for us to attach a anesthesia circuit. So what is happening here, I'm not sure if you can see, but you can take an endotracheal tube and put it down the patient's mouth, or you can put it down the nostril, one of the nostrils. And then in the picture on the left, you can see the tip of the endotracheal tube. You just want to place it as close to the glottis as possible to give you oxygen, to just keep oxygenating your patient. The other question is, how are we going to maintain anesthesia? TIVA, total intravenous anesthesia, is ideal. It would be great if you can do that. What that means is you need to have maybe 2 pumps if you're going to run maybe propofol and an opioid. As we speak, in our low middle income countries, you may not have those provisions for 2 pumps. Sometimes you may have just the 1 pump, and in many institutions they do mix the propofol and the opioid in one syringe and run that infusion. Again, the caveat to that is you need to have the skill in running TIVA, because the surgeon will not be pleased if they want a still patient and the patient is coughing and moving at critical moments. For example, if they're doing an esophagoscopy, you have a moving patient, there's a high risk of perforations. So understanding the procedure and making sure you give the anesthetic that's required is really important. So if we can give TIVA, all hope is not lost. We can still anesthetize our patients. As you can see in these images, you have a rigid bronchoscope, which has room and provision of a side port where you can connect your anesthetic circuit and run your oxygen and inhalation through there. And also the image that I showed you previously with the endotracheal tube that's sitting just close to the larynx, the glottis, you can run your oxygen and inhalation agent through that. Short of that, you can still run your TIVA with ketamine and an opioid boluses if you don't have a pump. Just remember, it's desirable to have a dry airway and give some anti-sialogogue to make that happen. And then maybe just a few tips and tricks that talking to people and the things that they find useful to them. Everyone sort of has a device, their go-to device, and one of my colleagues loves the bougie and tends to use it, yes, in the usual way where your coude tip is what's going in, but she does love to turn it the other way around, especially when the patient has hypoglossal tumors that are distorting the airway. So everyone does have a device that they like. Another one of my colleagues likes to have a Miller blade because sometimes it's just the best thing to use. It's small. It doesn't occupy as much space as your Macintosh blade. The other thing I want to mention is video laryngoscopy. And a lot of us on this call must be frowning at me saying this. But yes, they are not available in our setting. But if you do have, if video laryngoscopy is something that you can get, it should be your first option for success rate. If you're teaching, it's easy to teach without delaying instrumenting of the airway. So if you have access to it, it should be your first plan. And then if you can instrument the airway, it might be better if you put your tube in the nose versus orally, because its chances of it being displaced are lower than if you put it orally. When you intubate the patient and then the surgeon has to put in a shoulder roll, do check your tube position after the shoulder roll has been placed, just to be sure that the tube hasn't moved or gone down one way or come out. Particularly for cases where they want spontaneous breathing, but they don't want the patient coughing as the scope passes, it helps if the surgeon puts in some topical local anesthetic at the cords and then subglottic. Use your dexamethasone and use it in a reasonable dose. If you intend to use it for airway purposes, you need to use at least 0.2 milligrams per kilo and can go up to 0.5 milligrams per kilo. Anything less than that might do something, but for airway edema, it might not be significant. Epinephrine nebulization is your friend. Don't be afraid to use those. We must always remember to manage pain in these cases. And then they're also high risk for postoperative nausea and vomiting. So we need to use a multimodal approach for that. And then if you think you're going to use if you think you might need a nasogastric tube, put it in before surgery, because some of these surgeries are very disfiguring and they take out the frame and then you have nothing to latch on to help you put in that nasogastric tube. And then just a reminder about some things. When some anesthesia machines don't have auxiliary oxygen, but you have your common gas outlet and you can make use of that. The image on the left has ETT connector, and you can connect your nasal prongs to that and give your patient oxygen via nasal prongs, or you can connect your T-piece to that. Considerations postoperatively, where is the patient going? Again, for LMICs, it might be desirable to take the patient to an ICU. If there's no ICU space, we should probably not do that case until a bed is available. If it's a case that could potentially be HDU, but that can be avoided if we can do the case earlier in the day, then consider putting the case earlier in the day. And then for some patients, you might want to consider some respiratory support postoperatively. Again, the things that you use for respiratory support include your high flow nasal oxygen, your CPAP, or non-nasal intermittent positive pressure ventilation. A lot of this is high-end and sophisticated for many LMICs, but there's a YouTube video on some improvisation on how you can make your own bubble CPAP. And I think that's something that we can use, because the supplies that they use is stuff that we commonly have in our everyday work. So in summary, for cases like this, I think communication is probably the top most important thing. You need to approach these cases with caution and with the respect that they deserve. It's important to prepare and to plan accordingly. Thank you for listening.
Very nice talk. Thank you, Mary, for the beautiful talk. It was very interesting how you shared the different improvisions. I'll request you to stay on for questions at the end. I'd like the second speaker to be able to give her talk as well. Allow me to introduce Dr. Melissa Brooks Peterson. She is an anesthesiologist in Aurora, Colorado, and is affiliated with multiple hospitals in the area, including UC Health, University of Colorado Hospital, and Children's Hospital Colorado. She is an associate professor of anesthesiology at the University of Colorado. I can't mention that medical campus, and specializes in pediatric anesthesiology. She received her medical degree from the University of Michigan Medical School, and we hope that we will learn a lot from you. We're looking forward to your talk, Dr. Melissa. And without further ado, I'll give you the space.
Usually best to make sure I unmute before I start talking. Thank you so much for inviting me. I am an anesthesiologist. I just was at the International Aerodigestive Society meeting, and I coined the new term aerodigestivist. And I am a pediatric anesthesiologist, but my primary love and where I've spent the last 12 years of my career is in the aerodigestive world. I'm lucky that I'm at Children's Hospital Colorado, and we have a very tight-knit and kind of well-oiled machine for aerodigestive care. And I want to share a little bit about that with you today, as well as share with you some of the things we do in the operating room. Even if you're not in a place where you do what we call triple scopes, I think how we perform our triple scopes can be applicable to individual cases, as well as any kind of combination case you do to examine and diagnose these complex babies. I don't have any conflicts of interest. I don't know how many of you know who Curious George is, but there is a great book where Curious George gets a job. And one of the jobs he gets is working in a hospital. I believe he breaks his leg painting, actually, and ends up in the hospital needing surgery on his broken femur. And there's a really cool cartoon in that book where he describes falling asleep under ether anesthesia. So if you've never seen that, I would highly recommend finding it. And I think it's hidden somewhere in this talk, so I'll see if I can find it. When we're working in the aerodigestive space, we are lucky in Colorado that we get to see every single new patient who comes to the clinic preoperatively. And we intentionally did that in our institution because the way that we're organized is we do 4 to 8 triple scopes every Thursday in the operating room. And each kid with complex airway, dysphagia, swallowing, nutrition, and respiratory disease has a very unique story about the way that they present. And complicated patients are no mystery to you guys, to all of us really, but particularly in the aerodigestive space. So what we found is that when I, for example, would be doing 6 cases in one day, my usual workflow would be to get that patient list the day before and to try to look at all the patient's charts. And it was a mess. Each kid with a very complex story, trying to keep in my head and in my little note cards I keep in my pocket the 6 different patients. So instead, we decided to see every new patient in the aerodigestive clinic setting to be able to assess them and risk stratify them. This is certainly true. You guys probably are familiar with the ASA patient illness classification guidelines, and they're really inadequate for our patient populations. I don't think that's something that I have to explain to you. But what we did, and this is the crux of our preoperative evaluation, is that we're actually present as the 4th physician in clinic. So actually today, right when I finish lecture, I'm overdue to go over to clinic, and I have 7 new patients who I'm seeing, each of whom have their own complicated stories. And it gives us some time and a long runway to get ready to take care of those patients. So anything you can do, even if you don't have a clinic or you don't have a way to see all of the patients in an organized fashion, one way to do it is to talk with your proceduralist team and say, own the difficulty in preparing for a case the day of or even the day before, and ask your colleagues to bring you the histories and the physicals and the name and birthday and any documentation for any complex patient so that you also create a long runway for yourself. So I want to talk a little bit, jumping to kind of the things that make our skin crawl, the main risks of anesthesia for aerodigestive. You know most of these: laryngospasm, bronchospasm, aspiration, post-intubation difficulties, post-extubation difficulties, and then some less common pneumothorax, pulmonary edema, usually based on breathing against a closed glottis. And then our cardiac complications usually are preceded by respiratory complications, which you all know, usually hypotension, bradycardia, pulmonary hypertension crisis, any kind of shunting, which we'll talk about, and then less commonly, thankfully, arrhythmias and cardiac arrest. So in Colorado and in most of the hospitals in the United States that have dedicated aerodigestive programs, we do what's called a triple scope. And what that means is it's 3 different evaluations. First, we do a pulmonary scope with a flexible camera through the nose. What that enables us to do is to get very early pictures on what the airway looks like prior to any sort of instrumentation. So starting in the nose, we get an idea of the turbulence of any kind of allergy or allergic pictures. We get an idea of the size of the adenoid and how they're situated in the posterior hypopharynx. And then we get a really good view of the oropharynx. We get some idea of tone, although under general anesthetic, of course, tone is dropped, and so it's not great. But we do get really good pictures of the way the epiglottis and the base of the tongue and the tonsillar pillars all interact to a varying degree of collapse and obstruction. Once the pulmonologist puts the flexible scope through the cords, we get a very good idea of whether the pulmonary anatomy is normal and how the trachea interacts. And then one key thing we do that wasn't touched on by Mary earlier is, at this point in the anesthetic, on purpose, we have only used anesthesia gas at this point. We have not yet started our TIVA portion of the anesthetic. And on purpose, once the camera is through the cords, we turn off the anesthesia gas and we sit in the trachea with our camera and we wait. The patient is spontaneously breathing. There's a little bit of oxygen flow being provided through the flexible scope. And we sit and we wait for the patient's minute ventilation to breathe off enough of the sevoflurane or any kind of fluorinated agent, that the patient gets light enough that they intentionally start coughing. And I know Mary talked a lot about keeping the anesthetic deep enough to avoid cough. But in this particular aerodigestive evaluation, we want to see what the patient looks like when they are natively coughing. That's to get an idea of the stiffness or floppiness of their trachea so that we can see when a patient gets ill and they have a cough, what happens. Do they need to have some kind of tracheal surgical procedure? Do they have tracheomalacia? Do they have bronchomalacia? Do they have compression from an innominate? And when we are able to lighten the anesthetic enough to get the patient to cough, and they do move around the bed, we have kind of a setup for one person protecting the IV so it doesn't fall out, one person, an anesthesiologist at the airway, sharing the airway with the pulmonology team, and taking live video of the patient coughing. So that's the first of the 3 procedures. Once we see the tracheal cough, then we want to make that light anesthetic go away as quickly as possible. And so at that point, we switch over to a TIVA, and we have our TIVA medication hooked up actually by just hand syringe as close to the patient's IV as possible. And we give a small bolus of IV anesthetic, followed by a continuous small doses to keep the patient deep under anesthesia. At that point, for the pulmonology team, they're going to finish taking pictures of the pulmonary anatomy, and they're going to wedge into a small segment of the lung and do a lavage. So that concludes the pulmonary part of the exam. So early pictures, assessment of the upper airway prior to any instrumentation, both a static and a dynamic assessment of the trachea, followed by anatomic evaluation and lavage. The pulmonologists, you can imagine, leave behind a fair amount of atelectasis, so we will get to talking about managing that. The second part of the procedure, we actually, in our operating rooms, we turn the bed 90 degrees and the ENT doctors do a rigid scope or a microlaryngoscopy, bronchoscopy. That's a very common procedure for you as well as for us. And we get high definition pictures of the larynx, the vocal cords, the tonsillar pillars, the base of the tongue, the trachea, the carina, and then the upper bronchi, the larger bronchi. And then our ENT doctors will size the airway to see if the patient's airway is what is expected for that patient's age and weight, smaller or larger. And of course, they're also able to assess for subglottic stenosis and any other type of narrowing of the airway that might explain the patient's symptoms. Once the ENT portion is done, so now we've done our first two portions of the aerodigestive anesthetic with an open airway. Now, once we're done sizing, our airway assessment is complete, and our ENT doctors leave behind a cuffed endotracheal tube. And that's where the anesthesiology team really gets to start getting back to work at resuming the patient's normal physiology. Once that endotracheal tube is in, we secure it. We hook the patient up to the ventilator, and then we turn the bed back so that our GI doctors can put a camera down through the mouth into the esophagus, all the way down into the first and second portions of the duodenum, and then take little bites or biopsies on the way out. They're also able to assess, importantly for our patient population, the presence or absence of esophageal inflammation and take biopsies to assess for esophageal eosinophilic esophagitis. When the GI portion of the scopes are done, which is usually quite short, maybe 5 to 7 minutes for that upper scope, we have been able to leave the endotracheal tube in, use pressure support ventilation and some pulmonary recruitment to get rid of the atelectasis. So we organize these 3 scopes on purpose in the order that we do in order to be able to get an open airway assessment with no instrumentation, followed by ending with an endotracheal tube to try to combat all of the atelectasis and lavage fluid that we caused in the first 2 portions of the diagnostics. We also designed the anesthetic and the operating room to enable everyone reaching the patient. So this is our schematic of how we set up our operating room. You can see the orange circles and the pentagon are our anesthesiologists, and then the pulmonologist side by side up at the head of the bed. And then one RN down at the bottom of the screen to the right of the patient to help stabilize the patient when they start coughing and to also protect the IV. And then the pulmonary technician who helps the pulmonary doctor do their bronchoscopy. From this schematic, once the bronchoscopy is done, we push the bronch cart back away from the patient's bed. So in this screen, it would be upwards on the screen. And we turn the green bed 90 degrees so that the head of the patient is sitting right next to the ENT cart. Can you guys see my pointer as I point it here?
Yes.
No. Okay. So we turn the patient 90 degrees. So the head of the bed for the patient for the ENT part is right here. And then the anesthesiologist still has access to the patient, and the pulmonary doctor, the pulmonary tech, and the bronch cart all go away. So this is just one schematic of how we set our room up. Of course, every location is going to be a little bit different. And as anesthesiologists, you guys will be the best people to help organize your own personal schematic of what this needs to look like for your own environment. We laugh that this is how we feel in the aerodigestive operating room. It's quite crowded, but the good news is we're all friends, we're not zombies, and so we're able to kind of all be squished in this space with a million carts and a tiny little patient to get our diagnostics done correctly. So I want to talk to you a little bit about emergencies in the operating room and things that occur in the aerodigestive space. You're all familiar with this kind of oxygen saturation, this kind of fast heart rate, especially while you're driving a camera into the larynx, into the trachea. Occasionally things get pretty serious and you start to have significant desaturations. I want to share with you, our emergency setups are pretty complicated, but at the end of the day, we're all doing the same thing. We're making the blood go round and round. We're making the heart continue to beat quickly. We're giving medications to support both blood pressure and cardiac output. And in the rare circumstance, supporting the patient with CPR. I want to share with you some information that we have ready at our hands that's also widely available. All the things we know that can go wrong in the aerodigestive operating room, mostly desaturation, laryngospasm and bronchospasm, also occasionally some respiratory distress and hypoxemia related to atelectasis. Down here on the right lower left corner of the screen, you can see a little plug for what's called the PD Crisis app. If you guys don't have this, but you have access to a phone or a computer, especially in the operating room, you can download this PD Crisis app. This is a QR code for the SPA website on where to find instructions on how to download this app. And this has about the top 25 emergency and complications of pediatric anesthesia, and entering in the patient's weight, you get automatic differential diagnosis, treatment, and management strategies and emergency plans based on specific pediatric crisis. We use this, thankfully, not regularly in the aerodigestive operating room, but if you have a pulmonary hypertensive crisis and it's been, a year since you treated one, it's a really nice app to be able to open and keep your head thinking straight, even in the setting of an emergency. What happened? Oh, here we go. The other so that covers kind of our big bad emergencies. I want to talk a little bit about the more subtle risks that we face in aerodigestive. You guys are all familiar with this, upper respiratory tract infections. This is a little bit of a schematic from a very good paper in clinical anesthesia that was published by my friend Britta von Ungern-Sternberg that reviews the approach to kids with upper respiratory tract infections. And in aerodigestive, as you all know, for complex airway and breathing patients, they are chronically ill. And when they do get ill, they have a hard time clearing their upper respiratory infections because they have compromised pulmonary and upper respiratory function. We try really hard not to anesthetize babies who have severe or moderate upper respiratory tract infections. And when we do need to anesthetize a baby who is essentially never well, we are very clear with our team and have very open conversations with both the Aero team and our families about the increased risk, what we expect to see, how to proceed, and then most importantly, because aerodigestive is a diagnostic set of scopes, making sure that our diagnostics will be interpretable in the setting of an upper respiratory infection. I explain it to parents and to our team that, we can do diagnostics in a child's airway who is ill, but that means we're really only going to be getting information about that child's airway when ill. So the size of the trachea may change, the way the patient's trachea moves and the way that it looks from an inflammation standpoint may change. The lavage results will change if a child is ill. And as long as our aerodigestive team can interpret the patient's needs and the patient's diagnostics in the setting of that inflammation, swelling, and illness, we will usually proceed, unless the kid is severely ill, in which case we recommend postponing. This is one score that we use. It's called the COLD score. Current signs and symptoms, onset of symptoms, the presence of existing lung disease, what airway device we're planning, and then what type of surgery. We know that the COLD score, based on increasing score, increases the risk of what we call perioperative respiratory adverse events, or PRAEs. Those are well studied also by Britta von Ungern-Sternberg and her research crew, as well as a few multidisciplinary groups in the US and Europe. And we know, you can see, when a kid has a COLD score above 12, it's a significantly increased risk of significantly increased risk of respiratory complications, and really in a linear fashion. So ideally, we like to see kids cold scores at 7 or below. And when we start to get upwards of the 11s and the 12s, we have a significant conversation with the team and with the family about whether we're going to proceed. So outside of mitigating, making sure we're anesthetizing the right patient on the right day, a huge part of managing aerodigestive risk is managing atelectasis. And this is the way I like to think about our respiratory tree. I also like to think about aerodigestive like this person. So this is my pulmonologist first sawing off one of the branches, and then my ENT doctor goes and saws off another branch. And then we have a serious problem because our nice, beautiful, bushy, well aerating, well circulating respiratory tree really starts to fall apart. This is a picture of atelectasis and the increased level of shunt that occurs when the alveoli collapse. The blood still flows by. The problem is, as you all know, the air doesn't get to the alveolar sac. And so you've got blood flow flying by that doesn't get oxygenated, which returns deoxygenated blood to the heart and creates a problem. The way that I conceptualize atelectasis in the aerodigestive operating room is with a stopwatch. And we run a pretty tight ship in the operating room, especially with our pulmonology and ENT team, that really, when it comes down to it, I can manage the anesthetic and I can keep a kid asleep. But in the absence of positive pressure ventilation or pressure support or CPAP into the airway, and with taking away the patient's native respiratory tone and thoracic wall tone in little babies who are mostly cartilaginous and not as bony as adults, time is atelectasis. So we try to keep our heads about us and our wits about us about the timing with which it's taking us to do procedures. And when we get to kind of an excessive or a lengthy amount of time, we start to have conversations about skipping parts of the exam that aren't critical, asking another clinician to take over, especially if it's a resident or a fellow or another trainee practicing or trying to do the procedure and they're struggling a little bit. We will frequently ask the attending to take over so that we can move along and avoid, and really with the goal of avoiding atelectasis. This is one way that we support a child's respiratory effort and their oxygenation and support avoiding atelectasis during our pulmonary flex scope. So this is a picture of one of our patients. You can see that this hand here on the left is Dr. Dieterding's hand, who's a pulmonologist. This is her flexible scope, and it's actually in this patient's nose right below my thumb. This hand up here holding the mask is my hand with the mask over the patient's nose and mouth. And if you lay the pulmonary scope kind of not necessarily straight up, but in this sort of configuration on what I call the squishy part of the face or the cheek, you can actually create a nice seal right over the nose, the mouth, and you can leave the pulmonary scope in place. This is key for not only supporting timing of your pulmonary flex scope, it keeps you from having to go in and go out and go in and go out through the nose and the oropharynx, and it helps mitigate the amount of mucus and saliva that's produced with every pass through the nose and mouth. When we're doing the pulmonary scope, if a patient significantly desaturates, we will go back and forth and do what we call doing the dance, and we will pulmonary scope for a while and take pictures. And then once the kid desaturates, we will put the mask on and bring the oxygen saturations back up with a little bit of positive pressure ventilation. So this is one trick you can use to help mitigate the effects, the negative atelectatic and desaturation effects of your pulmonary scope and help keep your patient more stable during an open airway anesthetic. It does require us being close. You can tell here my hand is definitely touching Dr. Dieterding or Dr. DeBoer, and we're kind of sharing also what we call butt space. We share butt space, and we're all kind of squished up here at the head of the bed, just like that schematic showed. So we occasionally feel a little crowded, but because we're all a team and we've been doing this together for a long time, we're totally okay with this type of environment in the aerodigestive operating room. Let's see. This is another, this is a more ill baby with epidermolysis bullosa, but this is another way that we mitigate desaturation in the operating room with a nasal tube with an adapter, an endotracheal tube adapter in the nasal airway. Your anesthesia circuit can hook up to this adapter, and you can provide high flow passive oxygenation to the patient while you're either putting this flex scope in the contralateral nair or putting a camera through the mouth. That's another way, especially if you don't have a side port on your rigid scope, or if your ENT doctors are doing something that preclude hooking up to their side port on their scope, you can still provide passive oxygenation via the nose. So we talked about the triple scope. So the entire time we are doing an anesthesia triple scope, we're maintaining spontaneous ventilation. And I know Mary talked a little bit about the option to paralyze, but in this setting in aerodigestive, we really never paralyze the patient unless it's a true emergency that requires like front of neck surgical access, which knock on wood has never happened in our aero ORs. We do maintain spontaneous ventilation. We maintain depth of anesthesia depending on what diagnostics we're looking for, a lighter anesthetic during the dynamic tracheal portion, and then a much deeper anesthetic during all the other portions. We do use a little bit of IV opioid for pain control, though we don't find that our patients waking up in the aerodigestive operating room really have much pain because they have gotten dexamethasone for airway swelling, and nothing that we do in the aerodigestive space is really painful. There's no incision, the GI biopsies don't hurt, and there's really nothing that we do that's painful. So what we try to organize is a deep, short-acting, what we call a clean anesthetic, meaning all of the medication is going to go away. The patient's going to wake all the way up in the recovery room and be able to cough and deep breathe and fix some of their own atelectasis. Backing up to also what we do in the operating room, once the ENT surgeon has placed the endotracheal tube, we exclusively use a pressure support mode of ventilation. That's to use a high degree of PEEP to re-recruit and get rid of all the atelectasis we just caused. And then also make sure that the patient is deep enough that we're seeing their own native respiratory rate, and we get an idea of how comfortable and how deep under anesthesia the patient is. Once we've connected the circuit to the endotracheal tube during the GI portion of the aeroscope, we avoid disconnecting until we're finished with the case, and we disconnect and extubate and go to the recovery room. That's to maintain the PEEP for a maximum amount of time of getting rid of the atelectasis that we caused in the first half of the case. Other things we do in the operating room, we talked a little bit about timing and efficiency, and this is really a no egos involved open discussion between all the team members, that if it's taking me too long to get the IV, my teammates will speak up and call a friend for me or get an ultrasound probe to try to help. If the pulmonology part is taking too long and we're acquiring too much atelectasis, we have an active conversation about that. If the ENT surgeon wants to add a procedure that they see something needs to be done, but it's going to take us too long to get the equipment in the room, we have an active conversation about timing and efficiency, not because we care about OR turnover, but because we care about time that is physiologically maladaptive for the patient who's already complex to begin with. Other things we can do in the operating room is utilize topical lidocaine and also IV lidocaine, 3 to 4 milligrams per kilo. We try to divide it between the epiglottis and the larynx, the carina, and then also in the IV upon extubating the patient and going to the recovery room to reduce coughing. We also will routinely use short-acting opioids, and we use a little bit lower dose and small frequent doses of fentanyl in order to smooth out the anesthetic, but to make sure that we're not rendering apnea. So maintaining spontaneous ventilation, but deepening the anesthetic in a multimodal fashion. Things we talked about, we also do, you've heard me talk about a combination of an inhalational and an IV anesthetic. And then we talked about the mask seal plus minus a jaw thrust or chin lift during the flex bronch. And then during the GI time with the endotracheal tube in place allows us to recruit the lungs back using PEEP and positive pressure to suction as needed and to really try to reverse that atelectasis. This is another way that we can deliver supplemental oxygen to kids that don't have as much obstruction, that don't require a mask seal in order to oxygenate. We can also invert the mask and flip it upside down and help maintain oxygenation that way. A couple pearls that we utilize for our complex patient population. Some kids are dependent on CPAP or BiPAP, and we always coach our parents and our team to make sure that they're bringing their equipment with them. We don't want to take the time to have to refit them for rescue airway devices. If they have one at home or at that they utilize, they need to bring it with them, because then we can just use that. And we know it already fits. We know that they're used to it. And it helps a lot. And then kids who are extremely high risk. So a severe reactive pulmonary hypertensive child who has severe OSA, we can do the procedure in 2 stages. We can first do the ENT part of the rigid scope with the high definition examination of the larynx, the subglottis, and the trachea. And then we can insert an LMA into the mouth and have the pulmonologist scope through the LMA. So there's the rare case where we change the order of our procedures based on the patient's risk factors and usually the anesthetic history of the patient. And then this is a little bit nuanced, but speaking definitely to what Mary talked about, communication is paramount. And you saw all of us crowded up at the head of the bed, but we really decide intentionally who is making the air go in and out, who's giving supplemental oxygen. That can be the patient by spontaneously breathing passive supplemental oxygen. It can be the surgeon or the proceduralist, so the pulmonologist delivering airflow through their flexible scope, the ENT delivering passive oxygenation from the side port of their rigid scope, or if all else fails, it can be me with a mask from the outside on top of the proceduralist scopes, just to make sure that who's making the decisions about what desaturation number is the threshold to make the oxygen level go back up, and who and how are we delivering that extra oxygen. It's a very dynamic procedure. We also spend a lot of time setting expectations. We expect our aerodigestive kids to get saturations in the 70s, in the 60s, briefly, while we are taking pictures and doing diagnostics. We expect a patient to desaturate when we wedge the pulmonary flex scope and do our lavage, because we're then only relying on the patient's spontaneous ventilation, and we can't utilize CPAP during the lavage because it will disrupt the seal that the pulmonary scope has in the distal airways. So we set expectations for the families that we expect their oxygen levels to go up and down, and we actively manage it by bringing the oxygen saturation back up and then doing some more diagnostic work. And then the oxygen saturations drop, and then we bring it back up with our mask. The other thing that we set expectations for, and the reason why I have this paper cut picture, is when we do something like a supraglottoplasty or surgical intervention, we always explain to parents, it's just like getting a paper cut on your finger. It's not just the paper cut that hurts. It's like the entire tip of your finger. So when we do little paper cuts on the supraglottis of a baby, they are going to get kind of a swollen, angry entire airway for a week or two. And that we have to have patience, and that our end goal is that those paper cuts on both sides of the aerial epiglottic folds are going to heal in about a week or two, but we have to be patient and let that finger or that larynx be a little bit swollen for the first few days. So we are very intentional about explaining to our families what to expect, having open conversations with our aero team about what to expect. So I hope I've shared with you a little bit that this crazy way that we do 3 scopes in one anesthetic is safe, that we have a system that's thought out and has been developed over a number of years with our multidisciplinary team, that although aero patients and airway patients can be quite sick, being a part of the preoperative assessment team is really helpful, and seeing the kids coming earlier than the day of with a longer runway to prepare is important. Anesthetic complications are rare. They are more rare when taken care of by people and an aero team who understands aerodigestive and who understands the nuances of managing all the things we talked about, atelectasis being the primary, emergencies being the secondary, and also managing the sequence of events in your operating room with a team who communicates well. That is all I have for you. Thank you to my family for supporting my 12 years of being an aerodigestivist, and I definitely welcome any questions or ideas.
Thank you, Melissa. That was an excellent talk. I kept laughing about some of the things that you were saying, the bat space and all. And I'm scrolling through the chat to see if there are any questions. If there's anybody who has any question, kindly raise your hand and we'll let you unmute to ask the questions. And while they're thinking about the questions, I had one to ask you. If you were to choose, this is a very unfair question, if you were to choose just 2 scopes that you would do between pulmonology, ENT, and GI, which ones would you choose?
That's a really good question. So if you're limited to 2 scopes, I would say that it depends on the patient. And that's, of course, like a great gray zone answer. If you have a patient whose primary complaint, even though they may have a multidisciplinary set of complaints, if their primary complaint is that when they get sick, compared to their siblings, they're sick for 4 weeks, whereas their sibling gets better after 4 days. If every time they get sick, they have a horrible croupy cough that lasts 6 weeks, if they have recurrent pulmonary infections, if they have uncontrolled cough variant asthma or wheezing, that tips us over into the lung and trachea side of the house when it comes to the aerodigestive kind of model. In those cases, I would prioritize the pulmonary scope and the rigid ENT scope. On the other hand, for patients who present predominantly with dysphagia and difficulty swallowing, and in the absence of a neurologic reason for those difficulties, and maybe their food getting stuck or their pain or their dysphagia also involves a cough picture, I would choose 2 scopes. That would be an ENT rigid scope to look at trachea and tracheal compression to address the cough. And I would choose a GI scope because that's steering me more toward an esophageal type of pathology. Now, that's also kind of speaking for my colleagues because clearly I'm not the one making the decisions about their lung disease, their potential presence of esophageal disease or GI disease, and not making decisions about intervening on their airway in a surgical way. But having spent 12 years in our aerodigestive program, the way that we are designed is during the daytime. So like right now, it's 10:15 in the morning in Colorado, and all of my friends are over in the aerodigestive clinic seeing all the patients, and they're all waiting for me to go see them. At the end of the day, once all 6 of our colleagues have seen every single new patient, we have conference from 3:30 in the afternoon until 5:30 or 6 o'clock at night. And we talk about every single patient, and each of us give our interpretation of that patient with our own specialty lenses on. What that does, and what I've been a part of that for 12 years. And so the spiel and the story and the history and physical of how these patients present really help guide what we predict that we're going to find in the operating room. So that's a long way of answering your question. If I was faced then with not being able to do a triple scope and having to choose 1 or 2 devices or 1 or 2 assessments, my recommendation on what to do for the particular patient would depend on their history and physical.
Thank you for the elaborate answer. Just a follow-up question. So when you do have your triple scope and you find that a patient would benefit from something endoscopic intervention, do you actually pause to do that? Or do you strictly just get them, triposcope them to do that diagnostic, and then you schedule an intervention later? Is it simultaneous, or is it one after the other?
So that's a really good question. We typically do not do a lot of like urgent add-ons where we've made a decision that this has to be intervened on right in that moment, and it's something that we see on the diagnostics. Our general approach is to only do diagnostics, and we're lucky that we can bring a patient, right back, or we schedule out 4 weeks where they can come back from New Mexico or come back from Oklahoma or come back from Montana to have their definitive procedures done. The real exception to that is our ENT colleagues with a very convincing story for laryngomalacia in, like, for example, an 8-month-old baby with chronic aspiration who has an NG tube, and every time they drink thin liquids, they failed their swallow study, and they have noisy breathing. That's a noisy breathing at rest, noisy breathing with a cough, always sound congested, sound a little bit like a bulldog. In those circumstances, we will occasionally schedule kids for aerodigestive triple scopes and a supraglottoplasty. The other thing we'll frequently do as a combination case is examination of the ears under anesthesia with tympanostomy tube placement in addition to triple scopes. The other combination procedures we'll do is anesthesia triple scopes with an adenoidectomy, or anesthesia triple scopes with a tonsillectomy and adenoidectomy. That's more rare. And then the only other really one I can think of is occasionally we will do a radiology study, like a high definition or high resolution CT scan prior to the triple scope diagnostics. So we normally only do diagnostic procedures, but there is the rare patient who we will do add-on ENT type surgeries that we can predict ahead of time the patient needs. The only other one I can think of is in a child who's been NG tube dependent and is now 14 months old and will not keep their NG tube in, and we know that they need a laparoscopic G tube placed. We will schedule those as a combination case with our general surgeons, usually at the end of our triple scope day. So we will schedule combo cases. It's very tricky for us to do that, and we really try hard just to do diagnostics on our diagnostic days.
Thank you. I still can't find any questions in the chat, and I'm too afraid to continue being the one who's asking. I do have another question while other people are thinking about the questions. So in the event that you do have, no, the question is gone. It was following up with what you were saying about the T-tubes, which was quite interesting for me to know about the T-tubes. I wanted to find out, so you do have the triple endoscopy, but there's also the issue about the drug-induced sleep endoscopy, which is not really a triple scope, but it can be a diagnostic. Do you tend to do that on your diagnostic days? I know maybe it wasn't the gist of your talk, but would that be considered something that is done? And would you then look for a way to do a DICE and the triple scopes, or would you just leave it at just the...
That's a good question. So we very rarely will do a DICE at the beginning of the procedure. If it's a super convincing need, like, for example, a 12-year-old with trisomy 21 who's absolutely failed CPAP and we're worried that we need to perform a surgical intervention, it's very rare for us to do a DICE at the beginning of aerodigestive triple scopes, truthfully. We will do it if we're forced and we really think that the pathway for this kid is going to be some kind of an upper airway surgical intervention, like an epiglotopexy or a base of tongue excision. But it's pretty rare. I'd say like maybe once or twice a year. Of the 300 or so scopes, 300, 400 scopes that we do, will we do a DICE at the beginning. It's doable, but it's not our typical practice.
Thank you. Thank you so much, Dr. Leah. I've been really trying to ask you the questions because Dr. Mary stepped out a bit. She sent a message about that. Leah, do you have any questions, perhaps? Okay. I can't see any person on asking any questions. On behalf of our team and the entire, at least most of the pediatric lecture series that we really want to thank you for this wonderful talk. We thank you and Mary for taking out the time out of your day. Your team is waiting. I hope you have a good day. And Mary, on the other hand, is just handing over the theater day. So you really have a lot on your plate. Thank you for accommodating all the surgeons. We love you. We'll always share the bat space with you. Oh, there you are, Mary. Melissa has answered all the questions while you were away.
I was listening.
Yeah. Oh, good. Good. So we really thank you and appreciate you for your time out to educate us about what you find important for us to exist together in one space, especially your most precious airway space. And please do accept our call when we call on you to give further lectures. I have really enjoyed your talk, Melissa, especially because between Mary and I, our turnover can be really tricky, but we've learned a lot and we shall be coming back for great talks. Thank you so much. Have a wonderful day and good night to all of you. Thank you for joining in.